Good afternoon. I am Dr. Joss Reimer, medical lead on the Vaccine Implementation Task Force, and I am joined by Johanu Botha, operations lead. Things continue to move rapidly in vaccine planning. Based on what the National Advisory Committee on Immunization, which provides guidance to provinces and territories, has shared with us so far, we are expecting that they will soon be releasing additional guidance on spacing between first and second doses. In anticipation of this guidance, today I can confirm that Manitoba will be delaying the second dose. And this is true no matter which vaccine we are talking about. This approach will allow us to immunize more eligible Manitobans sooner, and this helps protect us all. The reason for this decision at this time is based on what we're seeing in real-world conditions about the effectiveness of the vaccines that are currently authorized for use in Canada and around the world. These vaccines are providing a significant level of protection even after one dose. This means that there is more of a clear advantage to getting vaccine to more people sooner. However, we know this will require a number of adjustments to our campaign. Johanu and I will keep you updated on what the next steps will be because it's important to keep all Manitobans informed about changes to this rollout. As of this morning, we have given more than 80,000 doses of vaccine to Manitobans, including more than 50,000 first doses and nearly 30,000 second doses. Our first doses to the general population were administered this week, which is particularly meaningful to all of us who are on the task force, and I think also meaningful for all Manitobans. And this is what we have been working towards. We want to make the vaccine available to every eligible Manitoban who wants it. C'est ce à quoi nous avons travaillé. Offrir le vaccin à tous les Manitobans admissibles qui souhaitent être vaccinés. In fact, I'm looking forward to my own first dose later this week so that I can protect myself, my loved ones, and my patients. A while ago, when vaccine supplies were even more limited, I had asked healthcare providers to do an honest self-assessment of whether or not they met the intent of our eligibility criteria before making an appointment. This is still true. But I also want to encourage healthcare providers, home care workers, lab staff, correctional officers, staff in congregate living facilities, all of the groups who are now eligible, to do that assessment and then pick up the phone and make an appointment. We want you all to be immunized. People in these fields are often drawn to helping and healing others and might want to make sure that others who they perceive to be more at risk to be immunized first. But there's a reason why we put you at the front of the line. We need you to stay healthy. We need you to stay well. We need you to protect yourself and the people that you care for by getting the vaccine. Les travailleurs de milieu de la santé sont souvent portés par l'idée d'aider et de soigner les autres. Ils souhaiteraient peut-être que nous vaccinions en premier les personnes qui pourraient être, d'une manière ou d'une autre, plus à risque qu'eux. Mais il y a une raison pour laquelle nous avons fait de ces travailleurs le groupe à immuniser en priorité. Nous avons besoin qu'ils restent en bonne santé et en forme. Alors je leur dis, protégez-vous et protégez vos patients en vous faisant vacciner. With the approval of the AstraZeneca vaccine, I know that many Manitobans might have questions about how the three vaccines, AstraZeneca, Pfizer, and Moderna, are similar, how they are different, and whether one is better than the other. This is the simplest answer to this. Clinical and real-world studies have shown all of these vaccines to be effective in preventing COVID-19. And the people who have been immunized are much less likely to not only become infected, but also to have severe symptoms if they do become infected. And ultimately, that is the sign of a successful vaccine campaign. I often hear questions about how quickly these vaccines were developed and how quickly they became available. And sometimes this makes people wonder about the process. There have been clinical trials, there have been data reviews, all of the processes associated with a more typical vaccine authorization process. Data on these vaccines are growing all the time, and they continue to be very closely monitored. In fact, the whole world is watching as these vaccines get rolled out. I want to encourage Manitobans that we know more about vaccine safety than we do about the safety of any other medical intervention in the world. We monitor all reactions that may or may not be related to the vaccine if they occur after the vaccine, and report them up to the national level. This type of reporting system doesn't exist for any other medical intervention, for any other prescription. So we know far more about the vaccine safety than we do any prescription that I might write in my clinic, for example. So for me, the development of these vaccines shows what we are capable of on an international scale when there's a strong collective will to protect people's health. There are differences among the vaccines, absolutely. There are differences in how we can store them and how we can transport them, from the ultra-cold Pfizer to AstraZeneca, which can be stored in the fridge. But they have all been tested and they have all been found to be safe and effective. I also want to highlight that none of these vaccines can give you COVID-19. In fact, none of these vaccines even have the virus or any part of the virus in them. The increase in the types and overall supply of vaccines is a good thing. Manitobans want to know, which vaccine should I get? And my answer to Manitobans is this: be immunized as soon as you are eligible with the vaccine that is available. And with that, I'd like to turn it over to Johanu.
Thank you very much, Dr. Reimer. I am Johanu Botha, Operations Lead on the Vaccine Implementation Task Force. As Dr. Reimer noted, the shift to focusing on first dose immunizations and extending the window for second doses will shift our vaccine operations. Let me assure you that this work is now underway and adjustments to our plans will be made. As Dr. Reimer noted, we will be providing regular updates to you on what this will mean for our vaccine campaign and how we can accelerate our plans by focusing on first doses, at least in the short term. However, I also want to reassure Manitobans who have already had their second dose appointment booked at our super sites. We will honor these appointments, and we look forward to seeing you when it's your turn. Our super sites were this week busy. We began offering immunizations to the general population, and we began, as Dr. Reimer has noted, with our oldest people, aged 95 and older, and First Nations people in Manitoba, aged 70 and older. Since then, we have been regularly updating and expanding the criteria to include more people. And today, we are expanding the criteria again. It now includes people aged 89 and older, and First Nation people aged 69 and older. Appointments can be booked in Winnipeg, in Brandon, Thompson, and in Selkirk. The call center has been fielding calls every day to make sure we connect people with appointments as quickly and as efficiently as possible. While vaccine supply in Manitoba has stabilized, we are still building and ramping up our plans to be ready for Q2 starting in April, when we really expect to see vaccine volumes to jump. We are putting key infrastructure in place to support that work. Our new super site in Selkirk will begin delivering vaccinations next Monday, and appointments are being booked now. The first super site in Southern Health, Santé Sud, will also open in Morden later in March. And our super site at RBC Convention Center in Winnipeg is expanding operations and will be able to provide 6,000 doses a day come mid-March. In total, the province plans to have as many as 13 super sites in the second quarter, which will be used to provide immunizations, but also serve as hubs for our focused immunization teams and our pop-up clinics. As we noted in the bulletin earlier this week, the Vaxport pilot project is underway in Thompson, and we expect to deliver 1,000 doses through that model to several communities in about 2 weeks as we pilot that model. The task force will have more details to share on the plans that have been built for the North in the coming days. But for today, I can say that this is important work and critical to the successful rollout of the campaign to all Manitobans. So, as we build towards Q2, we have set our goal is to have a daily maximum capacity of delivering 20,000 doses of vaccine a day. That would allow us to meet our current planning target of delivering 1.5 million doses of vaccine throughout the second quarter. Right now, our daily maximum capacity is at nearly 12,500 doses a day, which is an increase over the last week. Once the vaccine supply stabilizes and we open additional sites, we expect to be able to rapidly increase the number of vaccinations we're performing each day. To help accomplish this, we also have put our distributed model in place for doctors' offices and pharmacists to provide vaccines. About 500 of these locations have applied to participate already, with over 300 approved so far. This has helped us to move the needle again on our daily maximum capacity. Now that the AstraZeneca vaccine has been approved, we are in a good position to start delivering that type of vaccine when it arrives in Manitoba. When you consider all of the locations where Manitobans may be able to be immunized in the weeks and months ahead, whether that's a super site or a pharmacy or a pop-up clinic or with a focused immunization team, we're talking about hundreds of locations province-wide. We're building from Manitoba's deliberate and safe starting point to deliver the largest immunization campaign in our province's history. We will continue to make progress and be able to expand quickly once more vaccine arrives. I'm so proud of our team and all of the work they're doing so that I can speak to you about all these plans. Thank you to all of those who are putting in the hours to make this campaign a success. It's thanks to your hard work and that we're able to be reaching thousands of Manitobans over this campaign and protect them from COVID-19. And with that, I'll turn it over to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from Global News, Brittany.
Good afternoon, Brittany from Global News. Dr. Reimer, how long is Manitoba anticipating being able to delay second doses, and by how much will that adjust timelines for when people can get their first shot?
Yeah, thanks for that question. So we intend to follow the NACI guidance, which I believe has not been released yet, but we are comfortable following, up until as much as a 4-month delay, should that be what NACI guidance advises us to do. As far as what it means for timelines, our planning team is working on that as we speak. These studies have just come out, and so this is quite a bit of brand new information for our team. But certainly the whole goal of this is to speed up the ability to reach all Manitobans with the first dose. So we do anticipate that all Manitobans will be reached much quicker than the original plan of ensuring that the second dose occurred at the 3 or 4 week window.
Thank you. And we touched on this in the technical briefing, but I'm wondering if you can talk about who AstraZeneca is meant for and why people shouldn't be concerned with that initial trial that was showing only 62% effectiveness when you were saying we're seeing more like 80% with the directions that we're going to be going with.
Sure. So to the first question, the NACI guidance, so the National Advisory Committee on Immunization guidance for AstraZeneca indicates that they're advising, at least for now, that we provide the vaccine to Canadians between the ages of 18 and 64. So we will be following NACI guidance on that. And we're right now trying to finalize who in that younger cohort would be at highest risk of severe outcomes, because we want to obviously protect Manitobans from experiencing those severe outcomes, and we also want to protect the healthcare system so that the ICU beds are available when we need them, whether it's for COVID or something else. So we don't have the final list of who will be the top priority groups, but we are specifically looking through the epidemiology and reviewing with a large group of specialists to ensure that we are effectively communicating who the highest risk people are in those age groups, most likely starting with the oldest of this younger age cohort, and then expanding both the age category as well as the health conditions from there. Can you remind me what the second question was?
I think you answered most of it.
It was about AstraZeneca. So the trial data is challenging to compare head-to-head between different vaccines. The trials were done in different populations at different times in different countries with different variants circulating and different amounts of virus circulating. And so what we see in the trial data is only one part of the full picture that informs how effective we believe these vaccines are. And one of the factors, even within the trial data for AstraZeneca, is that despite that 62% effectiveness that gets quoted, when the second dose was delayed past 12 weeks, they saw more than 80% effectiveness as a result of that delay. So that's one aspect that indicates that we feel that this is a highly effective option for people. The other thing is that we're now starting to see early data from other countries that have been using AstraZeneca. So just yesterday, a study came out of Scotland showing very high effectiveness for AstraZeneca, in some cases exceeding the effectiveness that they saw with Pfizer. And these real-world studies are what we rely on probably as much or maybe sometimes even more than the trial data, because it reflects more what we'll see in the population when we don't have the same sort of control about who exactly is included in the study and the perfect timing of doses. And so we're really encouraged to see in the UK that AstraZeneca has been performing better than the trial data anticipated. So my message to Manitobans is, you're going to hear a lot of numbers being thrown around, and we are reviewing all of those numbers all the time. But we feel very confident that all of the currently approved vaccines are effective and will be beneficial to protect you from COVID.
From the Brandon Sun, Colin.
Good afternoon. I was just wondering, do the projections and plans you presented at the technical briefing this morning take into account the change you're making regarding delaying second doses?
Thanks for that, Colin. So the information provided at the tech briefing reflected the information we had at hand at the time, which reflected the strategy at the time, which was booking second doses along with first doses. So hence, now that we have all this information from NACI and obviously waiting for direction and analysis from our medical team, we need to run all those analyses to reflect this new strategy, and we expect to have that information out quite soon.
In the projections you presented this morning, you had the, I believe, on the less favorable end that everyone would be getting vaccinated by the end of November. On the more favorable end, everyone would be vaccinated by the end of August. Do you expect that to meaningfully change with this new strategy?
I think what we can say at this point is that, the very nature of pivoting to this dose one strategy and temporarily delaying the second one is that we will get through the population faster. I think the math is clear there, so that we will see a shrinking of those timelines. We want to go through our analysis and provide the most accurate picture to Manitobans as possible before we put it out there. So we'll see better timelines. I think that's what the math will show, but the precise ones will have to come out within a few days.
From CJOB, Will.
Hi, good afternoon, everybody. Dr. Reimer, Canada's chief science advisor yesterday raised some concerns over delaying the second dose, saying at this point it's a bit of an experiment. So what is your response to concerns that there simply isn't enough solid data at this point to warrant a delay?
So we have reviewed data from BC, some local data from Quebec, from the UK, the US, and from Israel. And really across the board, we're seeing very similar results, showing that the first dose is protective in the real world, 70 to 80+%, which is excellent. That's excellent real world vaccine effectiveness. And some of the data goes as far as 2 months. We obviously can't have data that goes 4 months because the vaccines haven't been around that long. So we feel very comfortable with the data that we have in front of us, that it's been so consistent in so many different jurisdictions to provide that high level of effectiveness up until 2 months. But we also will be watching. And if there's any signs after that 2-month point that immunity starts to decrease, we can pivot again. So that is, I mean, that's the nature of science. We are always putting out our best plan, but then testing it and watching. And we need to be ready to adapt to new information as it comes in. So I think we feel that based on the information available to us, this is the best plan. We have seen protection in other jurisdictions that have gone this route, and we want to be able to give that same protection to all Manitobans as quickly as possible, and then moving on to dose 2 once we've given that first layer of protection to everybody.
Thank you for that. And on a slightly different topic, a Brandon man is filing a human rights complaint about how Manitobans with disabilities are being overlooked in the vaccine rollout. He says his request to have his son with Down syndrome prioritized aren't being taken seriously. So can you please respond to that point? And maybe more broadly, what would you say to other people living with disabilities who are waiting?
Yeah, so those people who have, whether it's physical or intellectual disabilities, there is data showing that they may have increased risk related to COVID, depending on what their disability is and the severity of it. So there's no question that these groups can be at higher risk. But we did look at all health conditions, including people with disabilities, to decide where we wanted to start the rollout. And it was very clear that the age-based approach, first off, encompassed a lot of people, probably the majority of people who experience disabilities, but also was the most efficient way possible to reach the highest risk people as quickly as possible. With the rollout of AstraZeneca, we will be starting to look at different health conditions and trying to ensure that the people who are highest risk in this younger age cohort do get prioritized. But we had to follow the data that we had. And so for Down syndrome, for example, there's a very large variety of severity within Down syndrome. There are some people who experience immunocompromise because of Down syndrome. There are certain heart defects that can be associated with Down syndrome, but there's some people who have largely very good physical health and still with Down syndrome. And so if we included everybody with Down syndrome, it would mean including those highest risk folks, but also the lower risk people. And it would mean doing it at the expense of including elderly Manitobans, because we don't have enough doses to provide to everybody at the same time. I would love to be able to offer vaccine to everybody who, well, everyone in Manitoba, but certainly everybody who's at any level of higher risk. We just don't have that luxury until we have more supply. But we are looking at every health condition that could be higher risk, including Down syndrome, and keeping them in mind as we have more doses available.
From the Winnipeg Sun, Scott.
Hi, hello to you both. Scott Billick, Winnipeg Sun. Question, just maybe some clarification, Dr. Reimer. Did you say that the province is comfortable with delaying up to 4 months, or is it just 2 months at this point?
So our intention is to delay up to 4 months, but we also plan to watch it very carefully. So if at some point we see that there's any sign that immunity is decreasing and that people are becoming susceptible to COVID, then we wouldn't go all the way to 4 months. Right now, the data shows us that the protection lasts at least until 2 months, and we know that immunity doesn't disappear overnight. So if people have a really high level of protection at the 2-month mark, they likely will still have a high level of protection a week, 2 weeks later, 3 weeks later. But if it does start to wane or decrease, we are going to watch that, and we are absolutely open to starting those second doses earlier than the 4-month period. Based on what we know about immune response to vaccines, we anticipate that protection will last likely until 6 months. That's what we see with other vaccines. But sometimes COVID behaves differently, and so we will be watching.
All right, thanks for that. And I know you guys don't have specifics on how quickly this is going to speed it up. Are you able to ballpark? Are we talking days, weeks, months in terms of speeding up? Like I'm not asking for a specific date, but in a general sense, is it days, weeks, or months?
Thanks for that, Scott. And the reason that the planning team is careful about that data at the moment is there's a couple things we have to consider to ensure that we provide the most accurate timeline out to ourselves to plan, but also to Manitobans. The key variable for us that we need to work through, and we'll work through it quickly, is while we know what is coming up in Q2, we have a good sense we'll get about 1.5 million doses. We don't have a great sense yet from the federal government on how that supply will be distributed within Q2. So you could see a scenario in which if we assume it's been distributed evenly, we can put out quite a rosy timeline, but theoretically we could get that supply coming in near the end of Q2, which won't meet that timeline. So what we're in the midst of finalizing is putting together a number of scenarios that takes that kind of distribution into account, so that we provide a transparent but an accurate picture of how much shorter, and I mean, it's clear it will be shorter, but how much shorter this timeline will be.
Thank you.
From CBC Manitoba, Bart. From CBC Manitoba, Bart.
Hi, can you hear me now?
Yes, we can.
Excellent. Dr. Reimer, given that we have 3 vaccines available soon and we have this delay in the second dose, can you confirm that if somebody gets a Pfizer, a Moderna, or an AZ vaccine first dose, that they will get the second dose of the same vaccine?
So right now, the advice from the National Advisory Committee on Immunization is to stick with the same product for dose 2. But there are studies going on right now looking at what we call interchangeability, meaning how effective it is to use one product for dose 1 and a different product for dose 2. So our current plan would be to provide the second dose of the same product, ideally the exact same product, the same manufacturer, not even changing, say, between the mRNA vaccines. But if we were to see from the science that there was equivalent or potentially even benefit to switching products, that's something that we could consider changing our strategy for in the future. But for today, the plan is certainly to provide a second dose of the same product that somebody received with their first dose.
Thank you for that. And I know you said it this morning, but for the benefits of the, TV cameras, can you describe in a little bit more detail the kinds of adults aged 50 to 64 that could be eligible for the AstraZeneca vaccine in a couple of weeks? For example, you had mentioned kidney and liver patients, people with compromised immune systems. Could you please elaborate on that again?
Yeah, so we're working right now with a large group of specialists to fine-tune the list of conditions that we found in Manitoba, in Canada, and throughout the world to increase risk of severe outcomes related to COVID. So the examples that I had provided earlier today that we've seen, particularly in Manitoba, have been high risk, are people who are on dialysis because of kidney failure. And also people who have severe liver failure to the extent that they now have cirrhosis. So those were the 2 examples that I had provided earlier because those have really stood out in Manitoba to be particularly high risk when we look at the people ending up in the hospital or those who have died related to COVID, especially when we looked at the under 65 population. As far as the rest of the list, we really want it to be the best possible product that it could be. So, we will release it as soon as we know how much AstraZeneca is coming in, because we want providers to have as much time as possible. Once they know how much dose they're getting, we want them to have as much time as possible to identify who in their practice or in their clientele would be the top priority. But until then, we just want to make sure that everything in there is easy to understand and does reflect the best data that we have.
From the Canadian Press, Steve.
Good afternoon. Given the AstraZeneca age recommendation of 18 to 64, does that bring you closer to making a decision on whether to prioritize essential workers and use some of the AstraZeneca for essential workers who are under 65?
Yeah, so where we're at with essential workers is we're still doing consultation, but we have a team who has been looking at a variety of different factors as far as, if we were to include essential workers, how we would prioritize them. So we want to do a little bit more of the stakeholder consultation to make sure that there's no key parts of information that we're missing before we go ahead and make that decision. But AstraZeneca is a good option for essential workers because of the ability to reach out to more geographies and specifically because of the younger target population that's been not approved, but recommended by NACI. So certainly that is quite front of mind for us, that if we were to move to essential workers, that something like this recommendation from NACI could fit well there, but we still have not made any final decisions as far as essential workers.
And I know you've got a lot of consultations underway and decisions to make. Has a decision been made on whether to extend the First Nations age differential for vaccination to Métis people and Inuit?
So we're still meeting with a variety of those partners. We have the Manitoba Métis Federation has been participating on a few of our different tables, and those conversations are ongoing, but I don't have any new announcements about that for today.
From CTV Winnipeg, Michelle.
Dr. Reimer, you mentioned kidney disease and liver disease, putting people at higher risk. Can you just explain that further? Are more Manitobans with those conditions hospitalized or dying, or is it just a matter of we just have a high level of those diseases in our population?
Yeah, that's a great question because it can be difficult to tease out whether a health condition is truly causing the higher risk or if it's just an association based on what our population experiences. So, for example, high blood pressure was noted in a lot of people who were hospitalized, but we also know that there's a large proportion of Manitobans who have high blood pressure. And so, when we compared it to the rates in the general population, it didn't stand out the same way as being contributing to, or at least not greatly contributing to those higher risks. But what we did see for people who are on dialysis is there was quite a substantial jump. So those people who are on dialysis experienced quite a disproportionate rate of severe health outcomes, such as hospitalization or death. And the same thing, when we looked at the deaths under 65, cirrhosis stood out at a higher rate than what we see in the general population. And that's true of some other conditions as well, but those two really did stand out more than many other conditions. But I do want to flag for Manitobans that those two are just examples, and we are looking at a larger list than that that we will share as soon as we have more idea about what's coming in for AstraZeneca.
Thank you. Also a question probably for Johanu here. On the dashboard, it says we have 59,000-ish immunizations planned in the next 28 days. Since we're not holding back second doses anymore, do you expect that to go up?
Yes, that'll be reflected in the plans that we put out in the next couple of days. It's a great question. I mean, we do expect people to move through the system faster now. So what that means, the numbers you're seeing right there for the next month or so really reflects the work of our focused immunization teams. So there might be a bit of a labor piece there too, but our team, our projections by Friday should be able to tease out how much that spikes up.
From City News, Stephanie.
Hi there, Stephanie Lasuk from City News. just wondering if we're talking about going past the manufacturer's recommendations here, and Pfizer showed, what was it, 95% effectiveness after the second dose provided in that recommended time frame, how much could the second dose decrease in its effectiveness if it is delayed?
That's a great question. So we don't have data on specifically these vaccines and delayed second dose because we're just in the midst of doing that right now. But what we see in other vaccines is that a delay of a dose can either have no impact or actually can have a positive impact on the immune response. And that's what we saw in the AstraZeneca trial as well. So we feel confident on the data we see from other vaccines that our immune system will most likely respond either the same way as if it had been timed earlier, or we might even get a greater boost in immune response compared to the earlier timing of the vaccine. The reason we were sticking with the manufacturer's dates initially was because we didn't know how long to expect the immune response from that first dose to last, and because we didn't know how great that immune response was after the first dose. So we saw some early data from Pfizer saying that maybe it was 52% effective after the first dose, but now that it's been out in multiple countries and throughout Canada, we're seeing much higher than 52% effectiveness after that first dose. We're also seeing sustained levels of antibodies going forward. That's tricky to interpret because we don't know what level of antibody is truly protective, but it is encouraging that the level of antibodies is not going down as we delay second dose. So really, just in summary, we're not now, and we haven't really ever been concerned that the second dose will be less effective by waiting longer. Our concern was more what happened in between first and second dose, which the data that we have now shows that we're probably quite well protected in between those doses.
And then I just wanted to ask kind of what you see as the biggest risk with this new approach.
I think the biggest risk is communication with Manitobans. Vaccine science is confusing. It's complicated. There's so many numbers getting reported out. And so I don't want our change to be seen as any sort of lack of confidence that we might have in these vaccines. So I think the biggest worry that I have is that Manitobans could interpret this as something concerning, or that they could interpret the second dose as not essential. And we do know that for long-lasting immunity, that second dose is really important. We don't want to do this again next year. We don't want to have to shut down businesses because a year down the road, our immunity has started to go down and the virus starts to circulate again. So for me, the biggest concern is not so much the science around the vaccine, it's getting the messages out to Manitobans so that they can feel confident in this process and that they feel that going for that first and the second dose are really important.
Our final reporter this afternoon from the Winnipeg Free Press, Danielle.
Good afternoon. How would a prolonged period between doses impact the province's immunization rollout plan? So will you have to expedite super sites and pop-up clinics to keep up with vaccine supply or ramp up hiring? And is the current immunization infrastructure limiting the ability to extend the dosing interval?
So the interval piece, I'll pass to Dr. Reimer, but it's a great question. Thanks, Danielle. I mean, so overall, our system can completely handle this switch. The nice thing is we'll just be able to move people through faster. So once we get to 20,000 doses a day, we'll be able to get through every single Manitoban getting a vaccination faster than if we had to give everyone their second dose when we booked. So I think our system is well capable of handling it. It's just a matter of, and this is the question that was asked previously, is how much faster do we get through them? And that specific timeline we will have to run calculations on.
Okay, thank you. And I was wondering how the province will decide which clinics and pharmacists in which regions will receive the initial AstraZeneca supply.
So certainly we'll be basing that on the eligibility strategy that comes from Dr. Reimer and her team, but we have an allocation model in place that takes into account population throughout the province. So we've looked at all the clinics and the pharmacists that have applied. We look at the population heat maps across the province. Obviously, we have to look at the supply coming in, and then we should be ready to deliver to those who are in the queue. The one nuance to that will be Dr. Reimer telling these clinics who and who should not be vaccinated.
Thanks, everyone. This concludes our media briefing.